these are some of the art that I've done.
Geez, that one's scary.
Yeah, that's kind of like, when I think of the eating disorder, that's kind of the picture that comes to mind for me.
It's pretty terrifying.
Yeah, it just feels more like a monster.
That's what it's like inside, like a monster that's telling you what to do.
Yeah.
Hi everyone, welcome to Psychiatry Simplified, the world's leading psychiatry channel for all things psychiatry and neuroscience related. I'm Sanil Rege, consultant psychiatrist, founder of PsychScene and Vita Healthcare. If you're new to this channel, be sure to like, subscribe, and turn on that notification bell. So let's get started. Today I'll be talking about anorexia nervosa, which comes under the umbrella of eating disorders. Anorexia nervosa is an eating disorder characterized by an abnormally low body weight, an intense fear of gaining weight, often called morbid fear of fatness, and a distorted perception of weight, the body image disturbance. People with anorexia place a high value on controlling their weight and shape using extreme efforts that tend to significantly interfere with their lives. Anorexia nervosa has the highest mortality rate of any mental health disorder, with an estimated all-cause mortality ratio of 1.7 to 5.9. What are the risk factors for anorexia nervosa? We have female gender. Having said that, can occur in both sexes. Being from the developed world where the thin ideal prevails. Having said that, a lot of this is also moving towards the developing world, so-called, because of globalization and influences, across the world. Migrants from the developing world, urban areas, undertaking life pursuits where body image concerns predominate, for example, competitive gymnastics and fashion modeling. Increased genetic heritability, family history of leanness, early menarche, controlling for body weight, epigenetic changes to DNA. Now, this is interesting because following periods of food deprivation, for example, the Dutch starvation, World War II, food repletion, or severe environmental stresses. Low self-esteem, common sort of characteristic. High levels of clinical perfectionism and emotional and sexual child abuse are also risk factors. What are the symptoms? Now, one of the clearest, we'll look at the specific DSM criteria, but one of the clearest symptoms is anxiety around food. This can manifest as refusing to eat with others, having rituals around eating, such as counting mouthfuls, eating from a particular plate only, eating only specific food, for example, or taking only tiny mouthfuls. Lying about eating, I've already eaten. Constant preoccupation with food, being moody or angry when asked about dieting. Other early signs include unusually thin appearance for that person, increasing concern about weight and disgust with body shape, wearing only baggy or concealing clothing, exercising too much, repeatedly weighing themselves, frequent checking themselves in the mirror, complaining about being fat, bloated, or feeling full, difficulty concentrating, restlessness, hyperactivity, changes in personality and mood swings, and obsessive compulsive behavior can be present. How is it diagnosed? We use DSM criteria for diagnosis. One of the important things to recognize is that eating disorders tend to sort of move across a spectrum. So you might start with anorexia, move along bulimia, come back to anorexia, sometimes end up with what's called eating disorder not otherwise specified. So the important thing to recognize is what are the cognitions around food and weight, and how is it impacting on the individual? What are the behaviors associated? Those are key principles that we keep in mind. So what we can see here is, firstly, we have restrictive energy intake resulting in significantly low body weight. 2, intense fear of weight gain or becoming fat, or persistent behaviors that prevent weight gain. And this could be, excessive exercise, for example. It could be, so besides restricting, other behaviors might be taking laxatives or other supplements or fat burners, etc. Body image disturbance, weight and shape, or persistent lack of recognition of the seriousness of the current body weight. So body image disturbance is a really important component. And of course, the lack of recognition of the seriousness of the low weight. And the severity is sort of classified based on BMI. As you can see, mild, moderate, severe, extreme. Restricting type. Now, restricting type, weight loss is achieved through dieting, fasting, and or exercise with no evidence in the past 3 months of binge eating or purging behaviors. Whilst binge eating or purging type, weight loss is achieved through self-induced vomiting and the misuse of laxatives or diuretics. So we've got two types, the restricting type and the binge purge type. How is anorexia nervosa treated? The treatment options, we've got medication, we've got psychotherapy, and in psychotherapy, we've got a range of evidence-based treatments. So we've got cognitive behavioral therapy, enhanced for anorexia nervosa, which is known as CBT, CBT-AN, which is the enhanced, or CBT-E. We have specialist supportive clinical management, which is SSCM. The Maudsley model of anorexia nervosa treatment for adults, MANTRA. Family-based treatment, FBT. We have focal psychodynamic psychotherapy, which is FPT. So all of these are evidence-based strategies for anorexia nervosa. And nowadays, treatment is moving towards keeping the individual in the community rather than intensive inpatient treatments. So we know that outpatient treatments with good support tends to work. Then we have pharmacotherapy. Now within pharmacotherapy, I've added some of these aspects, but the key principle is nutritional rehabilitation, providing food in a gradual, appropriate manner. Now this, of course, is done orally, but in severe cases, nasogastric feeding may be required. But this component is known as nutritional rehabilitation. So a dietitian involvement becomes crucial, and gradual feeding needs to be introduced to avoid the risk of refeeding syndrome. Because when the body's adapted to a starvation model, sudden administration of food at higher levels can result in cerebral edema, can precipitate Wernicke's-Korsakoff's, etc. So ones need to be careful. And supplementing thiamine, calcium, magnesium, phosphate all comes as part of the refeeding. So that is a core component. And then you've got all these other possible aspects that can be added on, such as low dose of antipsychotic has some evidence to reduce the overvalued ideation or the agitation that comes with the disorder. Zinc supplementation, some evidence. Stereotactic surgery or deep brain stimulation for the severe treatment-resistant cases. Ensuring the bone density, so DEXA scans are carried out, and improving bone density, whether this is vitamin D or other supplementation. And estrogen replacement therapy also has some evidence, but not necessarily for improving bone density, but generally for the condition can be prescribed. But this is, of course, requires endocrinologist input, specialist eating disorder specialists as well. So I hope that you found this overview on anorexia nervosa useful. If you did find it useful and liked it, leave us a like. Let us know, of course, what other topics you'd like us to cover as well. Hope to see you another time. Take care. Stay safe. Bye-bye.